Thank you all for having me here. It's been a long time since I've had the opportunity to speak at a DebRA conference, and it's really a privilege to see you all and to be back. So Amy, of course, gave you a brilliant overview of the genetics of EB, which really has a special place in my heart because it was the work that I did as a postdoc fellow in Yoni Wito's lab, working with people like Amy and many of you here in the room. So it's been a long time for me in the EB field. But what I wanted to do today, actually, one of the nice things about this meeting was that the organizer set up a Dropbox, so I actually was able to see Amy's slides yesterday. So I knew exactly what she was going to say, and I'm hoping that we don't overlap at all, but instead that I can sort of use her last slide as my first slide, and that is as a jumping off point from the genetics, in addition to all the benefits that the genetics have had for prenatal testing, as you've just heard, for accurate diagnosis, for risk prediction, for genetic counseling, for knowing the subtype of EB. Another sort of burning question about that is what can we do with the genetic information when we think about therapy, and that's really where Amy just left off. So I want to try and build on that idea during this talk. Some of what I'll tell you is work that's been done. Most of what I'll tell you is work that's ongoing in our lab, and I'll try to cross-reference others in the field who you'll be hearing from at this meeting, just so you can get a scope of how the different approaches are sort of talking to each other, if you will. And so Amy really presented the key problem, the key challenge that we have in EB, and that is, unlike some other genetic diseases where there are one or two very common mutations that affect many patients, in EB we have just the opposite. Almost every family, with the exception maybe of EB simplex, has their own sort of private mutation or two mutations. And this presents both a challenge and an opportunity when we start thinking about how to try and approach that challenge using different types of therapy. So the question really has been, is there a one-size-fits-all approach? Is there something that would work for, say, all patients with dystrophic EB? And so you'll hear in my talk and some of the others combinations of ways that people are thinking about doing this. So I see Al Lane is here from Stanford, so you all know about the Stanford gene therapy work. We have protein therapy work going on with Lotus, who's here also. And so these are approaches that allow you to replace the gene in its entirety or to restore the protein in its entirety, mainly in recessive forms of the disease where proteins are completely missing or the genes are completely inactivated. But then we have all these other types where you heard there are dominant mutations, one good gene, one bad gene. How do we correct the bad gene and leave the good gene intact? And some of these challenges are what I'll try and touch on in my talk. So I'm not going to focus so much on the specific mutations, but rather you'll see examples of different patients whose cells we've studied in the lab, and I'll try to work in the genetics as we go through the examples just to give you a flavor of what we're doing. So you've already heard, I think, about Amy's introduction, but again, I think the thing to bear in mind is that we have great variations in, oops, that was not a pointer, in both in inheritance patterns, so we have variations being autosomal dominant and recessive, and also clinical severity, as you all know, that can be very different among patients. And so this also presents a challenge because not every patient with the same mutation will have the same degree of EB. So we also have variability in terms of how the disease expresses itself in a given individual. So just to introduce you, I'm sure you've heard some of this already before. This is the skin, this is the epidermis here, this is the dermis, and then along this line is the basement membrane, where many of the proteins that you'll be hearing about reside. And these structures on electron microscopy are known as anchoring fibrils. These are composed of type 7 collagen, and really it's this junction that goes from type 7 collagen at its lowermost to the keratin filaments K5 and 14 at its uppermost, and everything in between that hemidesmosomal junction in the skin. These are incredibly strong, mechanically strong complexes, and when there's a weak link in really any member of this chain, we get the resulting forms of EB. Amy already mentioned that there are now 12 genes. I lost track. I think this one was 10. This is John McGrath's slide that he was generous enough to give me. But really, I think this gives you a snapshot. Now we're sort of zooming down onto that same region of the skin. This is the basement membrane zone, as we call it. These are the anchoring fibrils made of type 7 collagen. Here are those basal keratinocytes that cause EB simplex, and everything else in the middle, the various different forms of junctional EB. And so the challenge really is when we think about a therapy and you see that these proteins all sort of connect in an interlocking way, is how do we restore the integrity of this junction to patient skin? And so that's really the challenge in terms of getting the protein back in there at the right time, at the right place, and getting it to be expressed and to really restore that three-dimensional and architectural features of the basement membrane. So here's the challenge. For example, in recessive dystrophic EB, we would usually expect to see nice bright staining of type 7 collagen here across the basement membrane. In recessive dystrophic EB, again, because of 2 inactivating mutations, we see usually very little to none. And so we have a great advantage when we think about type 7 collagen, mainly because it's probably the only component in EB, the protein component, that's actually made by 2 cell types. It's made both by the fibroblasts below the basement membrane here, and also by the overlying keratinocytes. So this provides a special opportunity because when we think of trying to put the protein back in, we can actually think about coming at it both ways, from the surface. So from the top down, this would be, for example, in the form of a skin graft, so delivering genes or proteins through keratinocytes, and also from the bottom up. And this is really what's unique about dystrophic EB, is that because the protein's made by those dermal cells as well, we have a chance to sort of feed this junction in both directions. And so thinking about systemic therapies like you heard last night from Dr. Wagner, transplant-based therapies that come at the problem through the circulation and through transplanted cells as well as through skin grafts. So the goal really is then to think about ways of replacing this. So we know, again, in dystrophic EB, where the blisters form, we know the challenges, and we know the gene. So this was all done a long time ago now. It makes me feel old to say some of this. But also, I think the thing to keep in mind, and again, as you are all well familiar, is that EB goes far beyond the skin. And we think about systemic therapies like transplant. Really another great advantage there is being able not just to fix the skin, but also to try and come at some of these problems of internal organs using systemic therapies. So in a perfect world, you might imagine a scenario where we could do both. So here are the challenges I'd like to set up at the beginning for you to keep in mind to see how close we can actually think to coming to actually achieving this goal. So we know we have to recreate this 3D architecture, these links in a chain, which is not easy to do. If we want it to succeed, we know that expression must last for a long period of time. We can't just have these proteins in there transiently and expect long-term benefit. Importantly, we have to think about ways to target cells that live in the skin forever, basically, and those are called stem cells. We'll talk a lot about that in the next few slides. But these are cells who take up residence in the skin and basically pump out proteins and hopefully corrected proteins. These are the cells that normally live in your skin that replenish the skin every 28 days or in response to wounding and other challenges. And finally, if we want to really think about a successful therapy for particularly dystrophic EB, we like to think about it in 2 ways: outside in for the systemic effects and inside out in addition. So I want to show you this slide because I like this one now. I didn't like it for a long time, but this is 10 years ago, and flashing back in science 10 years is often a real eye-opener because things change so fast. When we first proposed this way of thinking about the world, we got a lot of pushback, and I'll show you some of it because I keep these things for entertainment. So if we wanted to think about using bone marrow stem cells, circulating stem cells for EB, again, this is in the view of 2002, when a lot of this is considered crazy. And so the great thing about using bone marrow cells from an outside donor is that the gene of interest, in this case type 7 collagen, is already present in the person's genome, assuming they don't have EB to begin with. because of 30 years of history in bone marrow transplant, the ability to infuse large numbers of stem cells and get them to engraft was well established. You can have lifelong repopulation, and importantly, reports in the bone marrow literature about, in other contexts, bone marrow cells contributing to skin wound healing in normal skin. This also would take advantage of these natural properties of stem cells to move around and home to sites of damage, which is now a theme that's becoming more commonplace. And finally, this important ability to do inside-out repair. So what we do, we write a little grant to the NIH to try and ask for money to do this work. And so this is a grant that I applied for in 2002. You can't see the title, but it says Stem Cell Therapy for EB. And this was the comment from the reviewer, who told me I was nuts, basically, that the PI thinks that a bone marrow cell could somehow change its identity to skin is nothing short of heresy. So we take these out and read them from time to time, and we'd love to be able to send these back to the reviewers after a while. Like, you want to send something back to your college professor who failed you? Same thing. So fast forward to 2010, and the question now is, where does it end? And so we now know that just about any cell can be differentiated into any other cell, and so not only was it heresy, it's now possible across many, many different. And so this finding, I think, has really transformed the way that stem cell biologists think about approaching disease, and has opened up really a palette to paint with that's sort of beyond imagining. And so what I'm going to talk to you about for a little bit today are these special cells called PS cells, and we'll talk in detail about that because they're so, I want you to go home with an understanding of how they work. But basically, by introducing 4 factors or fewer into a cell in an adult, we can shake the Etch-a-Sketch and bring that cell all the way back to its initial state where it didn't know what it wanted to be. So if it's become skin in an adult, we can transform it with these 4 factors, bring it back to 0, and then feed it things to differentiate it into anything. Bones, muscle, teeth, skin, you name it. So again, this is now 2010, 2012, the world is different. But at the time, we wanted to try and prove that initial concept, at least in mice. And so in collaboration with Jacob Toller, who's here or coming to the meeting, we had a lovely opportunity to collaborate with Jacob and his group and actually establish, along with Katsuro Tamai, who showed very much the same thing, you all know this work very well, that bone marrow transplant of different populations of cells can actually rescue the phenotype in the EB mouse model, which was exciting news and really provided the groundwork for the clinical trials that you heard about last night. And also for a trial that we started at Columbia with my colleague Mitch Cairo, who since moved on to New York Medical College, just 20 minutes up the road. I put this slide here because it really, for a PhD scientist, for me was really a monumental thing to be able to actually do this type of translational research and make a bridge from the lab across Broadway to the clinic on this side. I have a wonderfully supportive chairman in dermatology and the chairman of pediatrics who also really believed in this, and the 2 most important people, one's here in the audience, Kim Morrell and Maria Garzon, who are the most amazing pediatric dermatologists to let us do this. You all know Kim very well, and really without her this would never have happened. And Mazen Kurban is a fellow who did this work, now gone back to Lebanon. So you heard last night, I'm sure, about the trials in Minnesota in great detail. I just wanted to provide a little bit of overview. When we started the work at Columbia, because of Dr. Cairo's history in using non-myeloablative conditioning, which now you all know means we don't completely wipe out the stem cell compartment, but only partially, this particular regimen allows stem cells to be grafted in for patients to go through a period where they have a mixture of donor and recipient cells, and then to convert completely, hopefully, to the donor cells. You all know the differences, the pluses and minuses of doing full conditioning versus this approach. We started with this approach, again, because it was Dr. Cairo's sort of way of doing things. Our first case was a patient with recessive dystrophic EB. Here you see a difficult-looking mutation, but basically this is a frame shift mutation that leads to no functional protein in the patient. The parents, as Amy just mentioned to you, were consanguineous, so they were first cousins, meaning that this patient got 2 copies of the same mutation, one coming from each parent. The donor in this case was his older brother, he was a carrier for the mutation, but was also HLA identical, meaning that he could serve as the donor for our patient's bone marrow. So again, this is one slide that was very important to me because this was the day that we actually dosed our first patient. The trial went live about 2-3 years ago now, and this, I think, really, for me, was an incredibly memorable day. First use of non-myeloablative transplant using bone marrow to treat a skin disease. And so I'm hoping like 100 years from now, we're gonna look back and we'll all look like, I don't know, old scientists here in this picture. But for me, this was just an incredible experience. So our patient did very well in this setting. So this is before, and this is almost a year after. This is, again, before. After, you can see some clearing on his back. This is before, around his G-tube. This is after, so some improvement there. Importantly, he had started contracting on his hands. This seems to be slowing down now. He's come to the clinic fairly regularly. He's been seen many times since. His blood chimerism early on was nearly 100%, and his skin chimerism has been gradually climbing, now approaching 8 to 10%, almost 2 years after this procedure. So we're hoping, again, like the results that I'm sure you saw last night, that this approach will continue to bear fruit. I should say that there may be some confusion on the website. Dr. Cairo, since moving to New York Medical College, is now setting up the protocol there. It is still an active trial. We've enrolled a new patient in the Colorado site, and we hope now to continue enrolling patients for this protocol. So I'm excited, of course, to keep that going, but as a scientist, what really drives me is to find a way to do it better. And so what I want to do in the last few slides is to kind of give you a glimpse of the future. You all know, I think, that there's been, again, lots of excitement in the stem cell world. But what I wanted you to get a flavor for today is how can we improve the issue of using unrelated donor cells. So how can we think about a way to, instead of using unrelated cells, how can we use the patient's own cells and turn them into skin and other tissues, and then accomplish these same things, large number of stem cells, engraftment, etc. And so this notion of induced pluripotent stem cells is something that I want to spend a little time on. So these are big words, but really think of an Etch-a-Sketch. It can't be any simpler than to think of it like that. We start with biopsies from an individual. We grow fibroblasts usually out of the skin. That's an easy type of skin cell to grow. The idea of reprogramming means we introduce these basically erasers to bring the cells back to a zero state. And if these cells carry a mutation or 2 mutations for EB, we need to go through a gene correction step. So we'll talk a little bit about that to fix the particular mutation. And then the methods for pushing those cells into different other cell types has now been established. Our lab has worked on mostly keratinocytes and fibroblasts. There are now methods in the field for generating bone marrow from these types of cells as well. So the words really, induced means we do something to them to make that happen. Pluripotent, think of the word plural, so a cell that can basically do many different things. And stem cells implies that they're going to be long-lived, so if we can put them back into the body, we'll hope that some of them will stay there for a long time. So just in brief, I'll run through our experiment. So we wanted to show whether these cells can actually make skin, so we've differentiated them, we've pushed them to making keratinocytes and fibroblasts. From normal cells, we've also done the same from EB patient cells to show that the methods can be used on all. So this is a long list of things we have to do to prove that those cells have actually undergone a complete erasure of their initial cell fate of a fibroblast and gone back to a more potent state. And so these are the assays that we do in order to do that. The first thing we want to do is see if they start expressing markers associated with a primitive stealth state. And here you can see that they do. These are markers that tell us they've gone back to an earlier fate. Those were with control cells. These are the same experiments done with cells from an RDEB patient. And here you can see 2 different mutations. So this patient was a compound heterozygote for 2 mutations that both stopped the production of type 7 collagen. And here we can show that these cells behave in exactly the same way. So in each experiment, we're doing in parallel normal fibroblasts and EB fibroblasts just to prove that they, in fact, do the same thing. So one of the things we want to show is when we do take them back to a ground state, to a zero state, they should be expressing markers that tell us that they're again primitive. So ES cells or stem cells, you can see the markers that those make, and we compare our iPS cells to this line here. It shows that we've in fact taken them back to 0. This is compared to the fibroblasts they started out as, and you can see we've done a pretty good job of erasing the Etch-a-Sketch and bringing them back to 0. As Amy showed you, a karyotype proves to us that we haven't undergone any unusual changes in the chromosome complement, so both of these individuals started out as XY males, X and a Y here, so nothing has happened to their chromosomes, which is good. This is the experiment that tells us we actually have shaken the Etch-a-Sketch. So these are stem cells, these are fibroblasts. The red dots are what we want to remove by doing this experiment, and you can see here we've done that in both the patient cells here and the control cells here. So we've essentially removed the print that tells these cells to be a fibroblast, and we've taken them back to a state where we can now change the configuration of these red dots and make them do something else. We also then want to prove how potent are they, what can they make? And so this assay just tells us they can make skin, they can make fibroblasts, they can make internal organs. So we want to basically test their legs and see what can they make. And so here you can see they can make just about anything. That's a hallmark of a stem cell. Same thing here for the ones that came from our EB patient. We've made all 3 what we call cell lineages, all 3 cells that make up most of the organs in the body. And here, this is hard to see, I'm very sorry. My legends are cut off the side. But then, of course, we wanted to see whether they can actually make proteins for keratinocytes. Here you can see some of the keratinocyte markers down this side. Importantly, though, you can see here they're making type 7 collagen here in the controls compared to this one, which came from the EB patient. You see no red staining like you do here because these are not making type 7 collagen. And then finally, to really test whether they can form skin, we put them in a 3D culture model, and we want to show whether they can differentiate and form all 3 of the layers of keratinocytes. So we layer these on 3D skin constructs, lift them up to the air, and you see here terminal differentiation markers, meaning they can go very far down the lineage towards making keratinocytes. We turned our attention more recently, this is work coming out of the lab now, to try and do the same thing for skin fibroblasts, to try and come up with a way to make a cocktail of growth factors that will make fibroblasts. So very simply, same procedure, we grow the cells, we add things to them, and here you can see the disappearance of some of these and the reappearance of some fibroblast markers. Here you can see some staining. Again, this is type 7 collagen from normal fibroblasts and from iPS-derived fibroblasts. They're showing that they can produce type 7 collagen as well as type 1 and type 3 and some other markers of fibroblasts. And most importantly, here showing that they can pump out large volumes of type 7 collagen, which is really what we want them to do. And so basically here I've shown you that we can start with biopsy from an adult skin or a newborn skin, grow those cells in culture, add some things to them to erase their imprint, and now come up with 2 different ways of feeding those cells that will lead us to make 2 compartments of the skin. So that's great. Now we've shown that we can make these special cells into keratinocytes and fibroblasts, but what can we do about fixing them? Because we still haven't addressed the problem that for EB, they're still going to carry a mutation. So the last challenge is, of course, gene correction. So I'm just going to show you this concept just to show what people are thinking in the field. This method called zinc finger nuclease, basically think of as a very customized scissor. This is a special enzyme that's designed for each patient's mutation that allows us to go in, cut the DNA in a certain site, and do a repair process that will basically replace the mutation for the normal gene. This is very expensive technology. It has to be custom made for each individual mutation, but this looks to be the way of the future. There are now some additional derivative technologies of this called TALENs and other ways of doing this. But basically, this gene correction step would be necessary to start with an EB patient's own cells, come up with a way to correct the mutation, and then use those corrected cells to regenerate their skin. Okay, well that's great. But again, being in a lab, we have the opportunity to dream and think even further ahead. how can we do this even better than that? And so, of course, I introduced to you at the beginning the notion of doing combinatorial therapies, grafts from the outside and transplant from the inside. But the real question was, could we come up with a better cell type, even better way to do this? And so the last thing I want to talk to you about is the use of revertant mosaic cells to do this even better. And so revertant mosaicism is again a big word that basically means on many patients with different types of EB, they will report patches of their skin that, quote, never breaks down, or I've never had a blister in this site, or another way of looking at the skin visually that you'll see there's a clear difference in the way the skin looks in a certain site. Over recent years, investigators around the world have begun studying these patches of revertant mosaic cells to actually look and see whether, in fact, the cells in these patches have spontaneously corrected their own DNA. That sounds like science fiction, but it actually has happened, not just in EB, but in some other diseases as well. And so the word revertant mosaic, again, is a horrible, confusing word. It basically means a self-correction of a mutation. And so mosaic just refers to the fact that on the same person, they have a patchwork of a normal patch and a patch that still has EB. So revertant mosaicism, think of it as spontaneously corrected cells on the skin of someone with EB. And so this is a slide again from John McGrath, who has outlined them here for us. And you can see these are patches of skin that never blister. Again, the thinking is that there's a region or a stem cell in this compartment that undergoes a correction. Again, it's not in the same place as the original mutation. It's somewhere else in the gene. But when it happens, it's basically like a teeth on a zipper. So if you take out one tooth, you get a mutation, but if you replace another one, you restore the integrity of that gene or the protein. And when that happens and it's in a cell that's in a stem cell state, that revertant cell can become part of the skin in that region and lives for a long time. So here's a report in the JID from 2 years ago that shows this phenomenon in recessive dystrophic EB. So here's the normal looking patch. Here's the affected patch. So a biopsy from here shows no type 7 collagen. A biopsy from here shows essentially normal looking type 7 collagen, which is truly remarkable. And this is compared to healthy control skin. You can see in the patch, there are beautiful anchoring fibrils here. So if you were looking at this blinded, you would think that was essentially normal skin. So this just again describes the phenomenon. A few more examples. We don't know how or why this occurs, but the key thing to think of here is it only occurs in the epidermis. It only occurs in those keratinocytes. It doesn't happen in the fibroblasts. We don't know why that is, except to say that these are rapidly dividing tissues. And the other place that it happens most is actually in blood disorders. So it may have something to do with the fact that these tissues turn over so frequently. We have no idea what the genetics are behind this or why a particular mutation gets itself corrected, but we're just thankful that it does, and it gives us a population of cells to work with. So the idea is then to biopsy from these sites and culture keratinocytes from the healthy patch and use those cells as the starting cells for the iPS work, because then we've really tackled all of our problems. So here's another one, a second site mutation in type 7 collagen. I won't go through the details, but you can see a nice correction event has occurred here, and here's the normal protein. Here's the original mutation. You can see these letters change, and when the second mutation happens, it goes back to normal. So that's exactly what we'd like to do. So here's our old diagram. So can we make it better? Do revertant mosaic cells actually help us here? And in fact, they do in a major way. So again, we start out this time with patient cells, but this time, if we take that biopsy from a spontaneously corrected patch, what we've done is basically bought ourselves a free pass here at the gene correction stage, because now we're using the patient's own cells who've corrected themselves to make a new skin. So we've bypassed that expensive enzymatic stage of having to correct the mutation, and we can move directly to thinking about differentiating those cells into other specific cell types. So I'm going to close by revisiting our initial diagram, which is shown again here, just to say, have we met some of these challenges? So to create a 3D architecture, again, we've got to get stem cells into these wounds. If we have an intact type 7 collagen gene in the donor cells from iPS in particular, they should live for a long time and continue to express these cells, again, by virtue of being able to do this through systemic means as well as grafting. Getting permanent engraftment of cells should be achievable. And finally, the ability to use these cells basically to make anything, I think in the future really opens up a world of possibilities for EB. So I will close by just saying that you can't read that, I'm very sorry, but I think many of us in the field are hopeful at this point that these approaches of stem cell transplantation using iPS cells combined with gene therapy, with protein therapy, with some of the other things you're going to hear about over the course of the meeting, I think for the first time really give us a battery of approaches to think about what to use in a given context on which type of patients. And I just want to close with a little plea. We can't do this work without your involvement. It's absolutely essential for us to continue to have your support and collaboration, in particular for the Revertant mosaic studies where we need these excuse me, normal patches of skin. So please think about reaching out to the labs across the country who are doing this work. It won't be possible for us without your help and continued interest. So thank you for being here with us, and thank you for allowing us to do this work along with you. And so I'll just close again by thanking my colleagues at Columbia, Kim and Maria in particular, my EB colleagues who you know by their last names because they're hanging off the sign here. So you know all of those people, John McGrath, Yoni Wito, Amy Paller, and Lucky Alan Arbuckle, and a few others. David and Mei Chen, who have been really great supporters in our clinical trial in terms of analyzing the protein, and an amazing administrative team who really helped move this from the lab over into the clinic in a very short time. So thank you very much for having me back with you.